So welcome to the webinar. My name is Dr. Robert Coben. For those of you that don't know me, I am a neuropsychologist, and I've been working in the field of EEG and neurofeedback for about 20 years. Today we're going to cover a topic and results of a research project we did entitled The Impact of Developmental Trauma on Brain Function and Connectivity. As hopefully you all know, this course enables you to get CEUs through BCIA and or the American Psychological Association. If you are hoping for BCIA credits, a certificate will be sent to you automatically at the completion of the webinar or in the days that follow. For APA credit, any attendee of the webinar who wants APA credit must check in during the webinar to verify your attendance. So during this webinar, you will need to send an email to admin@integrated-neuro.com to get that credit. And that has to happen during the hour of this webinar, just so you know. The attendees' check-in times will later be sent to the person responsible to receive APA credit, which is Angelica Sadar. And then we will send to you an evaluation form for you to complete by August 8th. And then your certificate will be sent to you automatically as well. So those are all the requirements for CEU credit. And now we will start the webinar itself. So this is kind of a summary page of just to show you in a nutshell what we'll be talking about with some history and some background information on the effects of trauma, the methods and the findings of our two studies, and then we'll finish with some conclusions and implications. So developmental trauma is a term that was first came into being by the Complex Trauma Task Force, where they coined the term developmental trauma because most maltreated children do not meet the criteria for post-traumatic stress disorder. PTSD also cannot capture the multiplicity of physical, emotional, and sexual abuse issues and the resulting symptoms. PTSD as a diagnosis does not also encompass the developmental effects, as what we're talking about are children that are abused or mistreated in very young ages, oftentimes. It doesn't include such as self-endangering behavior, self-hatred, self-blame, chronic feelings of ineffectiveness, loss of body regulation, such as sleep, food, self-care regulation, food, and self-care. You'll be seeing us talk about all of these topics on the right-hand side in turn as well. So there's a series of studies done in the early 2000s called the ACE studies, stands for Adverse Childhood Experiences Studies, where they studied the linkage between epidemiological and neurobiological evidence of the effects of childhood trauma. They assessed hundreds of individuals in the first 18 years of their life and focused on 8 adverse childhood experiences, including emotional, physical, or sexual abuse, witnessing domestic violence, parental discord, growing up with a mentally ill family member, substance abusing or criminal household members. And they categorized these, and each one was considered what's called an ACE, and your ACE score became the total number of these events you experienced in your lifetime. And from surveying more than 17,000 individuals and families, they found that 10% of them endured emotional abuse, 28% physical abuse, and 20% sexual abuse. So according to that population, almost half of them suffered one of these types of experiences. The information from medical review of systems, physical examination, and ACE study questionnaire form the basis for studying health-related behaviors and problem sources. And they looked at mental health disturbances, physical disturbances, substance abuse, impaired memory, sexuality, perceived stress, anger control, and risk of partner violence. The number of ACEs were summed and used as the dependent variable that would predict these outcomes. At least one ACE was present in 64% of the population, and as ACE scores increased, so did the number of comorbid outcomes. So that means that in their population, approximately 2 out of every 3 individuals had at least one ACE adverse childhood event. This shows you the relationship of ACE scores to the prevalence of mental health and physical disturbances. And basically the way you read this graph is that the ACE score goes across from left to right. So the higher the score, so within panic reactions, you can see here that the higher the ACE score, the higher the likelihood of panic symptoms in someone's life. The same is true for depression. By the time you get to 4 or more ACE scores, half the population had significant depression. Also true for anxiety and for hallucinations as well. You see the same pattern in sleep disturbances, severe obesity, and multiple somatic symptoms. So these adverse childhood events have a great propensity to lead to mental health and physical problems later in life. This is the relationship of ACE score to the prevalence of substance abuse and sexual disturbances. Again, the ACE score predicts an increase in smoking rate, alcoholism, and drug abuse, as well as injectable drug abuse, and also predicts sexual promiscuity and sexual dissatisfaction. You'll see the reference on the very bottom for the ACE study, but those are also listed in our references that will come at the end. This is the relationship of ACE score to the prevalence of memory, stress, and anger-related issues. And again, it significantly predicts memory impairment, with those having at least 2 to 3 ACE scores, at least 20% or more, will have memory disturbance of some type. Higher level of perceived stress, difficulty controlling anger, and a risk of intimate partner violence as adults as well. So we've learned that experiencing such traumatic events certainly leads to a high risk of psychological, physical, medical, and other problems in someone's life. So now what we want to try to do is understand what happens in the brains of individuals that are subjected to these traumatic experiences. So there have already been a series of studies that have shown that brain function and development is significantly altered by these traumatic events, specifically those of physical, sexual abuse, but also emotional abuse and neglect. And that we've learned that the type of abuse impacts the regions of the brain that are affected. This impacts structure, function, and connectivity, with alterations in limbic system, anterior cingulate, temporal and frontal gyri, insula, and precuneus regions of the brain, and with traumatic re-experiencing, so nightmares or flashbacks, or even feeling as if you're in that situation again, also being associated with brain alterations at the time it occurs. And this may include the insula, anterior cingulate, frontal, and temporal cortex as well. In a summary of this research, Marty Teicher in 2016 with colleagues published a study in Nature Reviews Neuroscience where they outlined the effects of childhood maltreatment on brain structure and function. and they found that if they were subjected to verbal abuse, there was a much greater likelihood that the auditory cortex would be involved, including lower integrity of the left arcuate fasciculus, which is the area that connects Wernicke and Broca's area in the brain. Diminished arcuate fasciculus integrity was associated with lower verbal IQ and comprehension as well. For individuals that witnessed domestic abuse, they found lower gray matter volume in the right lingual gyrus, which is an association cortex of the occipital gyrus, and reduced thickness in portions of the visual cortex. Witnessing domestic violence between the ages of 11 to 13 years of age had considerable effect on these findings. And in cases of sexual abuse, they found out that the primary visual cortex and visual association cortices correlated with the duration of exposure. So the longer it went on, the greater the problem, and that would also affect visual memory as well. It's been found that individuals with any form of physical or sexual abuse, so any abuse that involves touch perception, affects parietal lobe functioning as well, which certainly makes sense. There's also been work by the same group to show how it affects connectivity in the brain, and they've shown that plasticity in the limbic system is significantly altered, with structural connectivity being lowered in the anterior cingulate, temporal pole, medial frontal gyrus. So areas all over portions of the frontal, temporal, and limbic regions. And also that structural connectivity is significantly altered in the precuneus, which is in the middle of the parietal lobes, and the anterior insula, which is in the interior version underneath frontal and temporal regions into the limbic system. So very important brain regions for functioning emotionally, physically, aspects of depression, anxiety, awareness, memory, and even aspects of dissociative elements, as we'll talk about as we go through the talk today. Ruth Lanius, who works at a university in Canada, published a study here looking at what happens when individuals re-experience their trauma. And they found a high correlation with the bold signal in fMRI study with the right anterior insula and the anterior cingulate gyrus. Also a negative correlation with the inferior frontal cortex, implicating inhibition of movement and emotional experience, and other regions of the brain surrounding these same areas we've talked about related to frontal, temporal, limbic, and cingulate regions of function. And really the only significant QEEG study to date, and there's been shockingly little EEG research on this subject. They did find some differences for those that have been abused, with children with abuse histories having higher left hemisphere coherence than non-abused children, and also greater left versus right coherences. So we sought out to study this a little further with a greater number of subjects and higher density EEG and modern EEG analysis techniques to understand what we could find from the EEG itself in terms of brain functioning and connectivity in these individuals. So we studied adults that had experienced developmental trauma, and we'll talk about those findings. So in study one, there's two separate studies. Study one involved 50 subjects that underwent 19-channel typical QEEG recordings, eyes closed and eyes open data. 34 individuals were in our experimental group, and that is they had a history of childhood physical, sexual, or emotional abuse. And within emotional abuse, we included neglect. So that is one category. Versus 16 healthy controls that were screened for psychological difficulties. They did not have any as adults, and they have no history of physical, sexual, emotional abuse or neglect in their childhoods. For post hoc analyses, the experimental group was divided into 2 separate abuse groups, 19 suffering emotional abuse or neglect, and 15 physical and or sexual abuse. And they were compared for some of our parameters as well. Study 2 involved 19 subjects that underwent what we call high-density EEG recordings, including 64 channels of EEG data. Again, 10-minute recordings in the eyes closed and eyes open resting states. And we had, of the 19, we had 12 experimental subjects with a history of abuse, and 7, again, normal, healthy controls that had no history of childhood abuse of any kind. As a side note, that's a relatively smaller group than study 1, and we are continuing to collect data to fill out that group. Our dependent measures included log power, or power in general in the EEG, source localized activations, and graph theory connectivity metrics, which we'll talk about in greater detail. So for this study, in the analysis of the EEGs, we used technology called independent components analysis. If you've not heard of this, the first study done on this was by Scott McKeag out of UCSD way back in 1996. So this is more than 20 years old as a form of technology applied to EEG. And there is a whole system called EEG Lab, which is a software system you can use to perform these analyses. And many cognitive neuroscientists throughout the world use this technique. On the left-hand side, you see a small listing of very esteemed journals that have published articles using this technique in EEG analysis. There are even individuals that are now using the same ICA technology for MRI and fMRI analyses as well. On the middle column, there you see groups of institutions that utilize this technology, which is certainly a highly esteemed neuroscience group. And then on the furthest right-hand side, you just see a sample from McKeag et al.'s original study where they showed the effects of transforming EEG by independent components analysis. So on the left-hand side under EEG, you see a listing of EEG channels. At that time, they used 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 channels, and then an ocular channel at the bottom, which gave them 14 total channels. And then after the independent component analysis conversion, you see the 14 labeled independent components. So what this does is it converts your EEG at your channel location into a component that includes all channels, but converts it into the type of EEG activity seen. So for example, channels 19, 13, and 14 are certainly muscle or EMG activity that are pulled out from the EEG itself, and the other EEG remains in the other channels unaffected. You can also see eye blinking activity, eye movement activity, heartbeat artifact, all sorts of artifact. And the procedure calls for you to remove artifact from the EEG and keep the remaining components that show only EEG activity. And in this case, what's remaining will show you different type of EEG activity. So you may have a component that shows alpha activity. You may have a component that shows theta activity in a particular part of the brain. In cases of seizure disorders, you'll have seizure-related components. And each of these components can then be processed in this software for the type of activity, the source localization of that activity, and then you can measure connectivity between regions based on that activity. So this is sort of a hodgepodge slide that shows you everything that can be done in turn. So on the left-hand column, you see another study, which was basically the study published by DeLorme and McKeag that sort of propelled EEG Lab as an open source toolbox that can be used by anyone for processing of this information. And they showed how components are created and how you create maps of components and can get spectral activity and even ERP activity from this information. On the right-hand side, we see here a sample of the EEG tracing that emerges from using this artifacting technique. Remember, this is a 64-channel EEG, so you see multiple channels there. On the right-hand side, now you see a spectral display that can help you look at peaks and valleys of frequency. So obviously you see our alpha peak here at 10 hertz. Beneath that, you see all the components that are kept. And in this case, there were 9 good components of EEG activity. And when you use independent components, what that means is that each component is statistically independent of the next. So each one will show you a different type of activity, which is why each one has a very significant map than the others. And then beneath that, you can see a 3-dimensional version of one of the components. And you can even pull out component properties where you can see the map, the EEG tracing, the spectral display, and then onto the dipole localization of those components. And then in the middle here, you see a horizontal, sagittal, and coronal view of the dipoles for each of those components. So we have 9 components localized to different brain regions. And you can very precisely specify where those regions are, and these are now source localized activations in those brain regions that we can later run connectivity analyses between. And we'll talk about how that's done. So here's an example of a connectivity analysis that's done between those dipoles. For that, we use a technique called Granger causality, which is a form of source localized multivariate connectivity where you measure causality. So this is very different than measuring coherence. Coherence is a correlational technique, often done at the surface of the brain, which when you compare it to measures of structural and affective connectivity, it is not as accurate. So coherence measurements actually can throw you off from a precise measurement of brain connectivity, whereas this technique, which is a form of affective connectivity, actually shows you source localized causations across regions of the brain. So the easiest way to think about this is a form of multiple regression, where you can use multiple points and you can measure causality from one location to another and vice versa. So you can measure reciprocal causality as well. So the bottom image is actually a measure we have of reciprocal causality where we can map that. So we can determine, does the right parietal lobe cause activity in the anterior cingulate more than the anterior cingulate causes that in the right parietal region? And we can get very specific details about these types of information. We then take all that information and we convert it into what are called graph theory metrics. So I'm going to explain what this is because this is one of our dependent variables. So by definition, a graph is a mathematical representation of a network, and it describes the relationship between lines and points in that network. The graph consists of points and lines between them. The length of the lines and positions of the points do not matter. Each object in the graph is called a node. We can then define nodes. Edges are the lines between the nodes, as are paths that connect the nodes. And we can define hubs that happen frequently. and we can define clustering where nodes sort of group together in certain regions of the brain. This is a typical representation of what's meant by graph theory when it comes to neural connectivity. As an example, you can see a study here done on subjects with autism, where they show on the right-hand side a typical normal graph theory representation of normal developing brains. And on the left-hand side, what you see in autistic subjects, where you see high density grouping or clustering of nodes and long lines between the clusterings or hubs. And those long lines represent the path lengths, which are extended or stretched, which means that their longer range connectivity shows great dysfunction. And that's what's been observed in autism. So we can measure the path length, which is the average length of the connection, the radius, which is the shorter connection, and the diameter, which are the longer connections. And just some operational definitions here. Clustering coefficient is a measure of the degree to which nodes in a graph tend to hang together or would be hyperconnected. Global efficiency, I'll just skip one here, is the measure of how efficient a network is. So if you have a very low number, you're going to have low connectivity. If you have a very high number, you're going to have high connectivity. Average path length is the average number of steps along the shortest paths of all pairs in the network. So it is the average efficiency of all the paths in the network. The radius is the minimum distance in the network. So it is the shortest connections, and the diameter are the greatest distances between nodes or the longest connections. So we'll talk about the results for radius and diameter, which tell us differences between short range and long range connectivity, with the radius being measuring short range and the diameter measuring long range connectivity. So now we get to our findings. So study 1, we're looking at all of our subjects that had 19 channel data recordings. We're going to talk about the results for power, source activations, as well as connectivity graph theory measurements. These are the findings for eyes closed power changes. You'll see each channel represented in the graph in the middle. The control subjects are in red, the experimental in green. So the abuse subjects or subjects that had experienced abuse as children are in green, where the ones that didn't are in red. At each sensor location, anytime you see a gray line, that means there's a significant difference between the groups. And that p-value is at 0.0000000001. So these are not mild differences. These are highly significant. Some of the greatest differences you can see on the right-hand side include sensor locations FZ. So in terms of what we've talked about previously, over the anterior cingulate, potentially, PZ, which is back over the precuneus, and F7 and F8, which are near areas in the temporal frontal regions, and underneath those areas in the insula and deeper in the middle of the brain, again, would be the anterior cingulate gyrus, which other research has shown to be significant. And we can see significant findings in slow wave activity, in delta and theta, in alpha to low beta activity between about 9 and 14 hertz, and in high beta activity as well. So you can see across subjects frequency abnormalities in different frequency domains. Now we're going to take a look at the source activations within the 19 channels, clustering and grouping subjects that showed these differences. So in the upper left-hand corner, again, the green and red, you see the significant differences. The frequencies where they differed are in black. And again, these are highly significant findings. And then the clustering grouping you see maps of in the right-hand corner. And then there's source localizations or dipoles you see below that. So the clearest source localization for these individuals were of the left superior frontal gyrus, but also over the right hemisphere as a secondary localization. So they're showing bilateral findings over Brodmann area 6 predominantly. And again, we see a secondary finding in very similar brain regions, now in Brodmann area 8. So we're talking about posterior frontal lobe regions, very often involved in motor planning, execution, regulation of emotion, and areas underlying these regions of being very important for emotional regulation. In the 19-channel group, the ones circled here are the two we just talked about, but we can see there are other grouping clusterings as well. Some of these correspond to the left posterior hemisphere, some to the right hemisphere, and other regions as well. Although in the 19-channel clustering group, as you can see below in the dipoles, they tend to be on the outside of the brain instead of in internal structures. And we're going to talk about the meaning of that shortly. That's very important, a very important finding of these studies. But you will see that there are other clusterings that pertain to regions in the left hemisphere, over frontal, parietal, temporal regions, in the right hemisphere over temporal and occipital regions predominantly. And of course, we've talked about our midline posterior frontal regions as well. So one of the things we find is if we look at the other clustering groups and we look at all the way on the right-hand side here, we can see that in 19-channel EEGs, the dipoles all cluster on the periphery of the brain. When in fact, from other work, we know that a lot of times the damage or the dysfunction that is seen in these individuals is deeper in the brain, into the limbic system. So we're going to compare this to what we see in 64-channel recordings, and you're going to see some very interesting differences. So, but right now we'll talk about what we found in connectivity in addition to power and source findings in the 19-channel groupings. So in the eyes closed data, we see significant differences for path length and diameter between our groupings. And the path length for the experimental group is essentially double that of the normal group. And we see significant findings for diameter, again, a doubling of the connectivity finding. That means that compared to our normal controls, individuals that endured developmental trauma have twice the difficulty, double the difficulty in forming rapid connections between these brain regions as those without trauma. It has highly significant effects. So here we compare the experimental to control group. On the left hand, in blue are the path length. So you can see the experimental group is higher than the control group. And in green is the eyes closed diameter findings. Again, the experimental group has a higher diameter or lower connectivity, lower efficiency than the control group. For eyes open connectivity, we show very similar findings. There was a significant difference for path length, global efficiency, radius, and diameter. And interestingly, no significant difference between these variables if you compare two subgroups, physical sexual abuse versus emotional abuse and neglect. They do not differ on these variables. So what does that mean? That means no matter what type of abusive experience you suffer, your connectivity is disrupted in much the same way. That's a very important and interesting finding. Here you see that global efficiency is significantly lower in the experimental group compared to the control group. That means their speed of connectivity is less. Here you see path length in blue. Again, the experimental group higher than the control group. Radius in green, experimental group has a higher radius or lower short-range connectivity. And in tan, higher diameter than the control group, which is the most significant finding. And that shows that long-range connectivity is much more challenging if you've suffered these abusive experiences than if you have not. Again, a comparison between abuse categories and the control group. And it basically shows that for diameter, so the long-range connectivities, if you suffered physical, sexual, or emotional or abuse or neglect, your diameter is higher, or your long-range connectivity efficiency is lower than the control group, but that the abuse groups do not statistically differ. And again, we compare the abuse groups in all of these, and they don't differ on any of these variables. So again, no matter what type of developmental trauma you suffer, your connectivity is disrupted. Your brain is disrupted. The plasticity, the connectivity, the connections are compromised as a result. And we can use 19-channel EEG with this type of technology to document that. That's obviously a very important finding as well. So now we'll move on to study 2, where basically now the difference is we recorded using high-density 64-channel EEG in 19 subjects, where we compared experimental and control group. And our cardinal finding, again, was that there were significant power differences and source localized differences, and that now we can localize to regions including the left frontal subgyral white matter, the left middle temporal gyrus white matter, the right frontal paracentral white matter, precuneus, and right middle occipital gyrus white matter, combined with our previous findings, again, very close to the anterior cingulate gyrus in the posterior frontal lobes. Now you'll see results from all of these. So these are our clusterings with the 64-channel EEG. And I want you to notice the difference about how the sources on the right-hand side are all internal now. They're no longer on the periphery or outside of the brain. That is the difference between low density and high density EEG. To localize to deeper internal brain regions, high density EEG is in fact a requirement based on these data, at least for these subjects. Okay, so now we can look at clusterings and groupings. For example, the cluster in the top middle here that shows it deep inside the left middle frontal temporal likely limbic regions. We see another cluster next to that in the left temporal parietal regions, and then another one back in the middle parietal posterior cingulate precuneus regions, another one at the bottom left in the back occipital association cortices, and lastly in the bottom right in the right posterior occipital temporal parietal junction area as well. So these are now regions of the brain that are very similar to what we talked about in other neuroimaging findings that we're able to localize to using high density EEG with these types of analyses. So here's our first example. I'm going to show you some samples of individual cases as we move along here. So I see our clustering group number 3 shows a localization to the left frontal subgyral white matter, so deeper in the brain. This is at the very back end of the frontal lobes and extending over into the parietal post-central gyrus white matter as well. So we're talking about the motor and sensory cortices and the underlying white matter. Here's a case example localized to that same brain region. And this is the kind of result you get in an individual case where you can look at the three-dimensional nature of that, and you can see it clearly in the white matter tracts of the brain. Very important. And even deep enough where it gets to the insula white matter cortex as well, which is the area we've seen in some of the fMRI findings we talked about earlier. So getting to that point to see that is very critical in these cases. Here's another example where we saw localization to the left inferior frontal gyrus, Brodmann area 4, and to the white matter tract as well. Here's another example of IC5, which is of the left middle temporal gyrus white matter. And this is an area in the posterior left hemisphere underneath sort of Wernicke's area close to the fusiform gyrus into limbic substrate areas in the white matter connecting that to cortex as well. So very important regions of the brain for regulation of emotion, memory, and all sorts of things. Another area in the right paracentral lobule white matter, which is again in the frontal posterior region of the brain. And this also extends into the parietal lobes, like we saw earlier, into the precuneus white matter and the right parietal precuneus. To show you a case example of that, you can see this into the cingulate gyrus white matter, and again into the frontal middle frontal gyrus white matter. Notice in many of these instances, it's the white matter tracts that are being localized to. Here's another example of another independent clustering, this in the precuneus, which has been a critical area found in fMRI findings by Ruth Lennius, and into the occipital cuneus white matter as well. And here's another sample of that into the right parietal precuneus. You can see that in the back of the brain, which of course would be the area underneath and deeper into white matter structures underneath PZ approximately, for those of you familiar with surface EEG locations. The next one is of the right middle occipital gyrus white matter, right cuneus white matter, Brodmann area 18. And again, these are areas between about O2, P4, T6, again, in EEG surface terminology. Here to show an example of this, you can see this localization in the right parietal lobe of the post-central gyrus and of the temporal transverse gyrus, which is a region that leads from the temporal lobes into the limbic system as well. And again, in all of these maps, you get Brodmann areas and you get precise Talairach coordinates so that you can very precisely localize these sources. We're now going to talk about the connectivity findings and what you can look at in the 64-channel domain with this information as well. So here's an example of the Granger causality connectivity analysis done with a 64-channel recording where we had multiple dipoles. So each one of these circles is a dipole. The lines connecting them is the causality connection and it's measurement. And you measure the degree of connectivity from 0 to 1. And you can tell if there is too low connectivity or too high connectivity. What you can also look at, each of these planes actually measures connectivity in the time domain. So we can take times in the EEG. One of the values of doing independent components analysis is you can remove artifact out of the EEG without eliminating the EEG entirely. So if you have a 10-minute EEG recording, you can keep 8 or 9 minutes of data instead of more typical manual artifacting where you might only keep 2 minutes of data or less. So now we can subject all of that data to a time analysis where we can look at how connectivity changes over time. What you're going to notice in this analysis, so the blue is low connectivity. Anywhere you see a blue line reflects low connectivity between these source localized regions. As it gets yellow, the connectivity is raising, and it gets to orange or red, then you have high connectivity. And what we've seen in cases of developmental trauma is that there is great variability in their connectivity. So at one moment in time, it may have a very low connectivity. At another moment in time, it may surge in a specific region to have very high connectivity. And when you have high connectivity, your brain gets locked into a state, into panic, into anxiety, into depression, into dissociative elements. And that is very important for these individuals in understanding what's happening in their brain. Here's another example where we see the same process occurring. From low connectivity in plane 1, 2, and 3, here you start to see a gradual shift upward, and then rapidly to a higher hyper-connected state where their right temporal and limbic regions get hyper-connected for that period of time, and then they come out of it. They're back in a lower connected state, and then at the end, they're back in this high connectivity state. So that really aids our understanding of how their brains are oscillating very significantly, and that one of the jobs of any treatment should then be to try to diminish the amount of variability so that they can better regulate their brain activity and their function. Very important and interesting finding. Here's another example where you can see that happening over the right frontal to temporal region and extending across certain locations. And at all other times, and in even other locations, areas of low connectivity. So this is helping us understand not only the processes that happen in these individuals, but what can be done to help them in therapy also. So in conclusion, we've got about 10 minutes remaining here. So I'll go through some of this, and then we can hopefully take some questions. EEG analysis using independent components analysis is capable of demonstrating differences and regions of interest related to developmental trauma. Individuals that have experienced abuse as children show widespread power anomalies in multiple frequencies as adults, focused on theta, alpha, beta 1 frequencies, sometimes even high beta frequencies. Dipole localization suggests regions of interest that are likely critical to their challenges and consistent with other neuroimaging findings. These include midline frontal, medial to posterior left frontal temporal insula cortex, precuneus areas and regions of the right occipital, parietal, and temporal regions of the brain. And the majority of these localizations include white matter tracts in high density EEG that connect cortical to limbic regions of the brain. That is very important. There are extensive anomalies of connectivity that we could measure with this technology, suggesting that communication between nodes especially long-range connectivity is problematic in this population. And at least in terms of connectivity difficulties, abuse groups do not differ. So that is to say, whether you experience physical, sexual, emotional abuse, or neglect, your brain pathways and functioning are altered in a similar way. The limitations. 19-channel data appears to be significantly limited in its ability to source localize activity to deeper brain structures and to white matter pathways. Study 2's low sample size may limit some of its findings, and we are in the process of collecting more data that will be presented at a future point in time to help with this limitation. More data and types of analyses may help us find even more interesting relationships. What are the implications of these findings that we already have for intervention? Well, it tells us that in developmental trauma, the brain is very important. And I think if you're attending this webinar, you probably already believe that. But this certainly hits that home, as other neuroimaging findings have as well. So techniques that can help to improve brain functioning, like neurofeedback, and there are other techniques like meditation, yoga, EMDR, other strategies that can be very important. The regions of interest that we've identified may be points very important for feedback in terms of neurofeedback training. So with neurofeedback, we can specifically target regions and train them to function better. And that in terms of inhibiting amplitude or power in EEG, alpha and beta 1 frequencies and others may be very important. And connectivity training may offer further access to systems that seem critical to functioning. Up to this point, there's been no one that I know of that has done coherence or connectivity training of any type in developmental trauma, and there certainly is no research study to date that has examined if that would be effective. So that may be a very important implication stemming from this. Here are the references that we've used to form some of the literature review and other findings. You're all welcome to these references. We will also post the slides and a copy of this webinar on our website at a future point in time, so you'll have access to this. And if you need any of this information, of course, you're welcome to email us and get in touch with us. So I just want to thank a couple colleagues that have worked on these projects with us, and resources including EEG Lab and toolboxes used for these analyses. Our website is integrated-neuro.com, where you can get more information, and you can find our contact information there to get in touch with us if you have further questions. We can also do these types of analyses. Oops, let me keep sharing that. For individuals that are interested on individual cases and for research purposes. And we'd be happy to help anyone with that if they would like some assistance. And we can now take questions if there are any. So you can put those in the chat, or there's a Q&A where you can register any questions, but I'll respond to any questions that come in now for the next 10 or 15 minutes if you have them. Okay, so the first question is someone that uses 19 channels for recording rather than 64. And their question is, how valid are the 4-channel coherence training recommendations from you versus 64? So the locations in 19-channel data are close to what we get in 64-channel, but they're not as accurate. So, but the connectivity values do show very similar findings. So in terms of training coherence we believe the recommendations are very accurate, but I can tell you from our own experience in our clinic that if you were able to use high density EEG recordings, either 32 channels or 64 channels, we believe that it would be more precise and more accurate and even more effective. We have done a lot of research in cases of learning disability, depression, epilepsy, autism, ADHD, where we've shown this 4-channel multivariate coherence training to be very effective based on 19-channel data. We are now looking at data to tell us if using high-density locations is even more effective. We believe it is, but we also have shown and believe that 19-channel is effective as well. So it's just a matter of, how far you take this. The science here tells us that higher density EEG will give us more precise locations. It's then an empirical question if that helps neurofeedback to be more effective. And we're working on trying to answer that question. Next question. Are you still seeking participants in the 64-channel study? In fact, we are. The 64-channel study is done out of our clinic in Fayetteville, Arkansas. So if anyone would want to come here and volunteer and participate, or of anyone that would come here to participate, they would certainly be welcome. What is the hardware and software needed and cost of doing 64-channel EEGs? So there are multiple amplifiers that can do this type of thing. The one we use is what's called a neuroscan amplifier. To do 64 channels is quite expensive. To purchase an amplifier and recording device of that nature is about $30,000 currently. But we've also used an abbreviated version of that uses 32 channels, which I think has a similar effectiveness. We've compared 32 channels to 64 channels, and we've found that they are very, very similar. And there's other research that has shown the same. Through Neuroscan, you can now get a 32-channel device for $14,000, which is honestly not a lot more than if you were buying a brand new 19-channel amplifier, which many of them on the market right now cost about $10,000 or $11,000, at least the higher quality ones. The other possibility is if you have an amplifier like a Daymed that handles 32 channels, all you would need to do is just buy 32-channel caps, and your amplifier could already have the capabilities of collecting such data. Again, if you have individual questions about individual situations, feel free to get in touch with us at any time. What is the cost of being in the study? Well, there is no cost to be in such a study. It's done on a volunteer basis if you meet the study criterion. So anyone that wants to participate certainly can, as long as they meet those criteria. Time involved. Is that time involved in the study or to do the study? So the data collection for the actual study is about an hour and 15 minutes to do a 64-channel recording, and that is the only data collection involved. So it's not very extensive at all. So that's all that's involved in that. What feedback is provided to study participants? So our study participants anyone that is interested in feedback would receive feedback on their results for free. And people that are interested in using those results for neurofeedback we would also be happy to consult for those situations as well. John asked if there's cheap airfares to do the study. We do not control the airfare, so we can't impact that in any way. There was another question about what are the main differences between eyes closed and eyes open conditions. Well, very interesting. So we have not yet analyzed those differences. In terms of our dependent variables, which were power, source activations, connectivity, the differences between eyes closed and eyes open were not significantly different. So what I mean to say is, when we talk about the location of interest and the power and source activation problems in the study, and there's a significant difference at eyes closed, you get that same significant difference in eyes open. Okay, so they're showing similar findings. Both conditions are also showing very similar results when it comes to connectivity. The one big difference is the connectivity anomalies are greater, much greater, when their eyes are open. And that is something that we see clinically as well, that connectivity disturbances, by and large, in most populations, are greater with eyes open than eyes closed, although it can vary from person to person. Okay, let me see if I can get to some of these other questions. Mary asked, what are the criteria of the study? So to be involved in the study, to be in an experimental group, you have to be over the age of 18 and having suffered one type of a type of abuse, like we talked about, prior to the age of 18, and to be able to participate. So you have to be well enough to be able to undergo an EEG and discuss some of your symptoms. Those are the criteria for the experimental group. For the control group, you'd have to be above 18 again. You'd have to have no history of abuse and have basically no psychiatric or neurological history. Okay, that was that study. We are collecting data on children with developmental trauma, which would be a separate study, which we could certainly talk about at another time. Okay, let me get to some other questions here. Could this recording be done while the person is doing EMDR or brain spotting? How reliable would it be in terms of showing changes? So I would not advocate that. Obviously in EMDR, your eyes are moving back and forth, and a lot of the activity is going to be artifact as a result. While we could take out some of that artifact, I think you'd be in a much better position if you did your EEG first, did a course of EMDR, and then did a follow-up EEG to measure the changes. Okay, let me skip to some other questions over here. Someone asked that they have a child here in LA who may not be able to come to Arkansas. Can someone there do the acquisition? So if you wanted it for clinical purposes, yes, and we can help process that data. If you want them to participate in a research study, they probably have to use the same amplifier for us to be able to equate them. There's next question relates to how do you get trained to do coherence training if already trained in neurofeedback with Eager? So we do trainings on coherence training at our clinic in Arkansas. We also do them at major conferences like ISNR, where we'll be this October. And we do mentoring online where we can train you as well. Next question. Can 4-channel neurofeedback train deeper structures identified with 64-channel EEG recordings? We're trying to learn about that at this point in time. What I can tell you is we can see changes based on 4-channel multivariate coherence training in deeper localizations and the connectivity across those regions. So we believe it can, but we certainly have to study that more often. I've got 2 more questions here. A client who has frequent uncontrolled and aggressive behaviors, who shows problems on the TOVA, also a lot of low coherence issues. High coherence may be the issue of anger outbursts. Well, it's certainly possible that that is the case. And this gives me an opportunity to sort of explain something about comparing traditional QEEG to what we talked about using this type of ICA analysis. So in traditional QEEG, you manually artifact your data. You take all the data you have remaining, let's say it's 2 minutes of data, and you average all that data. And then you run a coherence analysis on that data. All you get, the only thing you can get at that point are values of the average. QEEG is done only in the frequency domain, not in the time domain. Doing an analysis like this helps us move. We are in the frequency domain, but we can also move to the time domain so we can measure how connectivity evolves over time. So if you want to do that, and we already help you process data, all you need to do is ask for an ICA analysis, and you'll have such an analysis will help us understand this information better. If you've never worked with us before and you want to, we can do those types of analyses for you. We don't charge anything different, whether you do a more typical QEEG analysis or an ICA analysis. So it's basically your choice. And then one person asked, how much time does it take to become familiar with EEG Lab? So you can learn to use EEG Lab by yourself. It took me about 5 to 6 years to learn how to do it. But we can also help train you, and we can help process data for you, depending on how you want to do this. So, you know, it's up to you, whether you want to do it on your own, or have us help you with that, or have someone else help you with that. And again, if you want to get in touch with us, feel free at integrated-neuro.com, where you can find our contact phone numbers as well. Okay, there don't appear to be any other questions. So at this time, I want to thank everyone very much for attending, and have a good day.